Hi everyone, my name is Joe Molyneux. I'm a consultant abdominal radiologist in the United Kingdom and one of the convener team for Radiopedia 2025. It is my pleasure to welcome you to the second Friday live stream of the season. We are now just 4 months away from the virtual conference, and this is the highlight of the radiology educational calendar. Right now, all over the world, we have speakers working on their lectures, case sets, and workshops. There's a huge backstage team polishing the audio and the video, creating English captions, and getting the conference website ready for the ultimate learning experience just for you guys. We really want you to feel the teaching we deliver, so there'll be a lot more interactivity, much more than ever before. You'll get a chance to view dozens of cases and learn the best ways to report from expert radiologists all week long. Registration is now open, so please do check out all the options. Remember, if you already have an all-access pass, the conference is included, along with everything else in the library. And the last time I checked, there were literally hundreds of hours worth of teaching available. If you live in one of the 125 low to middle income countries listed on the website, you can get free access. So please check out those options. We have tiered pricing with concession rates, so the conference is widely accessible to as many people as possible. Anyway, you know what to do. Go and check out the website and get yourself registered. A quick word about our posters. We have received hundreds of outstanding abstracts, and the team is busily sorting through them to decide which ones will be accepted for the virtual conference. I've looked at a few of the abdominal R poster abstracts, and I've been absolutely blown away by the quality. I can't wait for all of you to enjoy them in the next few months. Right, time for the lecture. Who better to teach you about neuroimaging than Frank Gaillard himself? I'm not totally sure he really needs an introduction, but just in case, Frank is the founder of Radiopedia, and he is a consultant neuroradiologist at the Royal Melbourne Hospital. This talk is titled Epileptogenic Brain Tumours, and Frank shares so many tips on what to look for and what it all means. Take it away, Frank.
Is the idea of talking about epileptogenic tumours even meaningful when most tumours surely can sometimes cause seizures? Well, I think it is, because there are a subgroup of tumours that not only cause seizures more frequently than others, but are more likely to present in patients who have a known history of epilepsy, rather than presenting with rapidly changing cognitive, behavioural, or focal neurological deficits with a seizure or headache, for example, and then a large tumour is identified. And the term that's sometimes used to capture this group of tumours is long-term epilepsy-associated tumours, or LEATs. Now, this isn't a real entity, in that the tumours that fall within this category don't really share anything in common histopathologically, really, other than the fact that they present with long-term epilepsy and their tumours. And exactly what is included in this group varies greatly from publication to publication. But gangliogliomas and gangliocytomas, as well as dysembryoplastic neuroepithelial tumours, or DNETs, are almost always included. And then in addition to these, a number of other tumours sometimes make the cut or don't. And among these are some recently described and only included in the more recent classifications of the WHO CNS classification of tumours, 5th edition being the current one. And these include polymorphous low-grade neuroepithelial tumours of the young, so-called plenty, papillary glioneuronal tumours, multinodular and vacuolating neuronal tumours, and sometimes angiocentric glioma gets mixed in amongst this group as well. Occasionally, other entities are included as well. The problem is, yes, this is how they present, But what do these look like? But the reality is that amongst this group of tumours, there are a number of different morphological appearances. And so when it comes to interpreting an MRI that has one of these, not only do they look different from each other sometimes, and other times look very similar to each other, but sometimes other entities need to be included in the differential that aren't on this list because they're not tumours. So what I propose to do today, instead of just going through one entity at a time, is to divide them up into the way that they appear to us when they present, into those that appear as smooth and featureless areas of signal abnormality, usually just high T2 signal abnormality, those that present as a lump that usually enhances to a lesser or greater degree, and those that present as cysts or bubbles, maybe with associated signal abnormality. The other idea that I really want to focus on is that of thinking about not just where a lesion is located within the body and what it looks like. And the what it looks like is definitely the thing that we as radiologists spend most of our time doing. But I want to stop and think about the who, because the demographics of the patient, the incidence of individual diseases, when the where and the what aren't helpful because they overlap too much, become really important. And that's an area that I've spoken about before, but more importantly, that we undervalue in radiology generally. So much so that I know when I was studying for my board exams, when I got to the epidemiology section, I would skip over it. Not only skip over it because I couldn't be bothered learning it, but because it didn't seem to be relevant. And I'd like to make the case for the fact that epidemiology, even though we do it badly, is an area that can be tremendously useful in shaping your differential and shaping how you think about tumours that otherwise look similar. Not just tumours, any entity. So let's jump into the first group of conditions. And here we start with an example in a 35-year-old man who presents with, guess what, seizures. And what we see here immediately is a very large area of high T2 signal. Very high T2, profoundly high T2, extending all the way inferiorly. And one thing that I would ask you to do whenever you're seeing something that may or may not be a tumour is to try and assess whether cortex is involved. Because if you're trying to distinguish between vasogenic edema versus tumour or tumour involvement, then the presence of uninvolved cortex or grey matter, where the edema just abuts it but does not extend into it, is very, very important. But as you go further down here inferiorly, you go straight from very high T2 signal tissue to bone. There is no intervening cortex. And if you had coronal images, please look at those. But you don't really need them to make this assessment. All of this tumour involves the cortex. And in fact, there might even be some bony remodeling. Look how thinned and scalloped the bone is here, suggesting that this entity has been here for quite some time, long enough to change the shape of the underlying bone. More superiorly, there's grey matter involvement here of the amygdala as well, and heading up into the insular cortex and frontal operculum. Now, when we move over to FLAIR, we see quite an interesting appearance here, which is that many areas of this tumour have reduced in signal intensity significantly. Not so much that they appear to be an arachnoid cyst, for example, where you'd expect the signal intensity to approach that of CSF elsewhere in the brain, but, lose maybe 50 to 80% of the signal. And when you compare the T2 to the FLAIR, you'll see that the majority of this lesion experiences incomplete FLAIR suppression. This appearance has been termed, when we're talking about tumours, particularly this entity, T2 FLAIR mismatch. And when you use that term, you're really saying, I think this is a diffuse adult type glioma, either an astrocytoma or an oligodendroglioma, and that the presence of this T2 FLAIR mismatch means that this is not an oligodendroglioma because of all the signs to help distinguish between astrocytomas and oligodendrogliomas. Other than calcium, this is the most robust one. When you see this, it is extraordinarily unlikely that a 1p19q co-deletion, and thus oligodendroglioma, is going to be present. So this is almost certainly a diffuse adult type glioma, an astrocytoma, and in a 25-year-old, it's almost certainly going to be IDH mutant. It's very uncommon for these sort of tumours in this age group to be wild type, just as it's very uncommon for a diffuse glioma in a 90-year-old to be mutant. And the thing with these tumours is they very, very frequently present with seizures, which naturally lends me to ask the question, how is it that some tumours cause seizures and others don't, and what factors influence this? Well, for rapidly growing tumours, ischemia is certainly being recognised as a feature, and that is presumably due to a combination of compression of the brain, but also possibly changing the microvascular requirements of the tissue, maybe stealing some of that blood flow from normal tissue to the tumour. In slower growing tumours, then chronic inflammatory change resulting in gliosis in the adjacent brain can also be a cause. And we know that gliosis from any cause lowers the threshold for seizures. In patients who have gliosis and encephalomalacia following closed head injury, or at the edges of a resection margin for benign disease, that will also influence how likely you are to have seizures. There are also changes that are really interesting from an integration of the tumour cells into adjacent neural pathways. And this is particularly true for gliomas, but also, and I don't know why, breast cancer metastases. Apparently, these cells create sort of synapses with adjacent neurons and lift the rate of spontaneous activity such that reaching the threshold for seizures is lowered. Iron deposition is something else that's relevant, particularly, say, in hemorrhagic tumours like melanoma. And we know that also because hemosiderin deposition at the margins of a resection cavity will also predict the likelihood of having post-surgical epilepsy. But the one that I want to dwell on a little bit, and you'll have to excuse me because this is a little bit of a rabbit hole I went down, but that I want to share with you because I found it really interesting, is the glutamatergic effects. And to understand what we're going to talk about here, we need to talk about IDH. Now, IDH as a tumour promoter mutation was only really discovered in 2008, which seems very recent considering how important IDH mutations have become in the classification of adult diffuse type gliomas. They've become the bedrock of the classification, whereby if you have a mutation, then you can be an astrocytoma or an oligodendroglioma, whereas if you don't have the mutation, then you're going to be a molecular glioblastoma. And to make matters more interesting, there's 3 IDH genes, IDH1, IDH2, and IDH3. Fortunately, we can ignore IDH3. That's the one that's part of the Krebs cycle. It's in the mitochondria, but it's a different molecule and it hasn't to date been implicated in any tumours. IDH1 and IDH2, on the other hand, are exactly the same enzyme. IDH1 is located in the cytoplasm of the cells, whereas IDH2 is within the mitochondria. And both of them have 2 copies, of course. 1 on each chromosome 2 and 2 on each chromosome 15. And therefore, each of those is producing or being transcribed and encoding for IDH proteins. We're just going to look at IDH1. It's the most common. It causes approximately 80% of the mutations that we encounter in tumours. But all of them catalyze the same chemical reaction, taking isocitrate and converting it to alpha ketoglutarate whilst producing some carbon dioxide and NADPH. Now, the alpha ketoglutarate then goes on and has various other effects. One, it's involved in many other compounds, but importantly, it's involved in many processes that determine DNA methylation of DNA and therefore affects how other genes are expressed. Now, what's fascinating about IDH1 mutations compared to other enzymes that get mutated is almost all other enzymes, when you mutate them, they lose their function. In this case, they lose their normal function in that they stop catalyzing isocitrate to alpha-ketoglutarate, but they gain a function, which is to take alpha-ketoglutarate and convert it to 2-hydroxyglutarate. And that is really quite uncommon. And that effect is profound on the cell, because not only does that mean you have far less IDH to catalyze the normal reaction, and now you have an enzyme that's taking alpha-ketoglutarate out of the equation and pushing it to this other metabolite, 2-hydroxyglutarate. But 2-hydroxyglutarate, being similar to alpha-ketoglutarate, is a direct antagonist. And through that mechanism, it inhibits alpha-ketoglutarate usual effect on DNA methylation, which in turn changes how genes are expressed elsewhere in the cell. The effect of that is that it causes cancers, and that's why IDH mutation is a factor that incites tumor generation of these low-grade tumors. But why are they so indolent? Well, because simultaneously 2-hydroxyglutarate is toxic to the cells that it accumulates within. But what has this got to do with epilepsy? Well, it's a third thing, which is that 2-hydroxyglutarate is very structurally similar to glutamate. And glutamate is the dominant excitatory neurotransmitter in the central nervous system, with NMDA receptors being one of the most common receptors, and therefore it has a positive effect on these, causing an increased likelihood of neuronal activity and therefore seizures. I know that this has got nothing really to do with radiology, but I find it amazing. We can understand through this genetics not only how it creates the tumor and how it results in epilepsy, but also on why these tumors are less virulent than their wild type. And importantly, 2-hydroxyglutarate, when it's in high enough concentrations, and it is in very high concentrations in these cells, can actually be detected with MRS. It's been well described in the research literature. It still hasn't really reached clinical applications, at least not in a routine sense. One, because to do the MRS well enough to be able to detect this quite small peak is not easy. And two, to a degree, it doesn't really change what you do. You still need to biopsy or resect these lesions to identify whether there is an IDH mutation or not. But the thing that I think is really important to understand, and something that when I first started reading about IDH a decade ago, is wild type is normal, which means if you take normal brain and get a pathologist to look at the IDH status, it will be wild type. The other problem is that low-grade tumors, histologically low-grade tumors, can be difficult to distinguish from slightly abnormal reactive brain. They can have astrocytosis, where the astrocytes look a bit reactive and maybe increased in number slightly. And so the difference between a molecular glioblastoma, meaning an astrocytic tumor that is histologically grade 2 but is IDH wild type, and a bit of brain that's next to another process, is not trivial. And this is where our reports are really important, because when the surgeon takes a biopsy and sends it to the lab, what they write on the specimen jar will frame the way that the pathologist will look at the specimen. And if all that the request says is query tumor, they are much more likely to interpret this as being an astrocytoma than if the request says query tumor or query reactive process or something else, which we'll come to later. And what effect does this have on the patient? Well, quite a large one, because if you take a bit of brain next to a reactive process, it's like, well, you don't have a tumor. Congratulations, you're fine. Versus you have an IDH wild type glioblastoma, the conversation is, terribly sorry, you're likely to be dead in a year, and now we're going to start radiotherapy and temozolomide. So the role of our differential in this context is very important. So understanding these molecular meanings and understanding the importance of our differential is critical in not setting up the surgeon and the pathologist to go down the wrong diagnostic pathway. The other question, leaving that aside for a moment, that I think is worth asking is, why is the temporal lobe so much more likely to cause seizures than lesions in any other part of the brain? And most of this has got to do with neuroplasticity, meaning that after the first few years of life when your brain is still developing really actively, most of your neural networks have been set in place and need to be quite resistant to change. You've learnt to walk, you've learned to talk, your visual system has set itself up. You don't want that to change rapidly. The one exception to this is memory. For memory to work, you need neurons to find new pathways and new neural networks to develop really quite quickly. And so the temporal lobe, particularly the limbic system, is very important in this process, and therefore the neurons within it are more likely to change their firing behavior. And there's this process called kindling where sub-epileptogenic activity, such as might be caused by chronic inflammation or scoliosis, can gradually self-reinforce to the point that you get epilepsy. And so a recurrent thing that you find is that lesions that cause epilepsy tend to be found in the temporal lobes. Anyway, that's enough of me banging on. I promise I won't go on this many tangents again. So let's have another look in this category of smooth and ill-defined featureless lesions. And here we have a 45-year-old woman who presents with seizures. And I'm only going to show this one study in this patient because it's actually just seen really on this coronal image, and we can see an area of gyral thickening or cortical thickening at the base of a sulcus. And if you squint and look carefully enough, you can see a trail of high T2 signal leading down to the ventricle. And this is a very typical appearance for focal cortical dysplasia with a radial glial band. The reason I'm showing this case is not because this particularly looks like a tumour, but sometimes in this 10-year-old, also with seizures, you can get an appearance that mimics much more closely a tumour. Here it looks mass-like in this projection. Now remember, if you biopsy this isn't a diffuse adult type astrocytoma, and therefore it will be IDH wild type. And so you want to make sure that you raise that possibility. And here there's a couple of clues. One, if you go away from that largest area, you can see a radial glial band. And this is dysmyelination that results from that migration of neurons from the periventricular germinal matrix all the way up to the cortex during embryogenesis. And so you see this stria of high T2 signal. But the other clue is that in other planes, it's much harder to identify. And even when you can see where it is, there's much less mass effect than on the axial would suggest. And that's because really this is a slight thickening of the cortex, blurring of the grey-white matter junction, and some abnormal signal in the subjacent white matter. So keeping in mind that focal cortical dysplasia can sometimes mimic tumours is really important. And similarly, this very appearance is seen in patients with tuberous sclerosis, where cortical hamartomas or tubers also have that radial glial band extending from the ventricle to the cortex. They are also high on T2, but usually they occur multiply through the brain. We tend to focus on the subependymal nodules when it comes to tuberous sclerosis. The thing to remember about those is, firstly, they are very small when patients are young. Secondly, they don't calcify until you're an adult. So looking for calcification on CT or gradient echo imaging, you won't find it in younger individuals. And thirdly, not all patients with tuberous sclerosis will have subependymal nodules and multiple tubers. You can have quite variable phenotypes, with some patients only presenting with one tuber, the so-called forme fruste of the disease. One last patient in this group, 70-year-old with seizures and memory loss. Now, this is a very different patient group to everyone we've seen before. This one's 70, and so the differential is going to be really quite different. But what you really want to know, and what is not always provided, is what do they mean by seizures? Do they mean seizures since yesterday afternoon and now their GCS is 4? Or do they mean seizures over the last 3 months and they've been neurocognitively impaired and maybe have some neuropsychiatric features? Those are very, very separate presentations, but they share very, very similar imaging with, in this case, increased T2 signal in the mesial temporal lobe here on the left. It's easier to see in this case, possibly on T2. There's some increase in bulk. Compare the temporal horns on both sides here. There's some increased T2 signal on DWI, but if you look at ADC, this will be facilitated. It won't be diffusion restriction, truly. And in this instance, no convincing enhancement. Now, if this patient was acutely unwell and having seizures, then you'd be thinking herpes simplex encephalitis. But if this patient is quite well and is having seizures over a time, and particularly if there are neuropsychiatric components to their presentation, then you really need to be thinking of autoimmune encephalitis or limbic encephalitis. You can divide this into 2 broad groups. Patients who present with autoantibodies, typically to surface antigens like NMDA receptors, and those that present with antibodies to antigens that are within the cells, and those are typically paraneoplastic. And that latter group tends to have a worse prognosis in that once you find the tumor and resect it and the antibodies go away, those cells, because the antigens were intracellular, tend to have been killed. And so there's no recuperation of function. Whereas in the autoimmune set, because those are mostly surface antigens, the cells are not functioning properly but can recover once the antibody is removed by immune therapy. And in this instance, this was a small cell lung cancer. Now let's get on to what's arguably the more complicated but actually simpler part of this talk, which is the ugly and enhancing lumps. And let's start by just looking at a case. Long history of epilepsy, 40-year-old female. And we see immediately here in the temporal lobe, surprise, surprise, an area of higher T2 signal on this FLAIR imaging with some central areas of maybe bubbly, maybe cystic, FLAIR suppression, but they're very circumscribed. It's not the whole tumor that's suppressing. If we compare it to T2, it's not quite as bright as before, except for that circumscribed area. It definitely involves the cortex. If we move to susceptibility weighted imaging, there is some signal loss implying either calcium or blood product. And to sort that out, you've got CT or phase imaging to try and see whether it was calcium on phase. In this case, it was calcium. On ADC, it's facilitated, meaning it's higher ADC values. And on post-contrast, there is some contrast enhancement. It's fairly subtle, but you can see it better here on coronal. You can see there's some phase artifact through the carotids at this level that mimics a little bit of faint enhancement, but this area is convincing. And so what is this? Well, the reality is that this tumor could be any number of conditions. It could be a ganglioglioma, gangliocytoma. It could be, they're a little bit old for a plenty. It could be a papillary glioneuronal tumor. Again, they're probably on the older side of things. It could be a DNET. So how do you pick it? What do you put the most weight on? Well, it's a combination of all of these things. But one thing that can be really helpful is going back to that idea of incidence. And wouldn't it be lovely to find out that one of these tumors was 20 times more frequent than all the other ones, because then that's the one you would favor. Unfortunately, trying to get a straight answer to this seemingly simple question is surprisingly difficult. These are the epidemiology or incidence as presented in one publication, the WHO current classification. And even within this one publication, you can't easily compare them. We have some where there's just no figures, and that's great because that basically tells you this is rare. So I don't know what number it is, but that's going at the bottom of the list. But when there are numbers, We have cases per 100,000 population worldwide, and this one is similar. So this suggests that gangliogliomas are less common than pleomorphic xanthostrocytomas, I guess. And then DNET down here, and this one's expressed as per 100,000 person years, and I don't know how to convert that. And so this is a frustration I come across over and over again, because realistically, this lesion could be any one of these. And if you were to order it purely on this incidence, then I guess it would be pleomorphic xanthostrocytoma, ganglioglioma, and DNET. I'm not sure where DNET would come into it. And then you put plenty and papillary glioneuronal tumour later on. And then you want to shape that differential by how it looks and who's it in. Because it's an older patient, you'd probably leave plenty out of it anyway. And because it doesn't enhance very vividly, you'd probably put pleomorphic xanthostrocytoma further down. And so you'd be left with ganglioglioma. And that's what it is. This is a ganglioglioma. The problem with ganglioglioma, or maybe it's not a problem, is that it can look like whatever it wants. It can range from completely solid and vividly enhancing, as in this case, or more frequently as a mixture of solid and cystic-y and calcified areas with areas of enhancement around the edges. It can be mostly cystic with a mural nodule on the side, more reminiscent of a pilocytic astrocytoma. But the reality of it is that when you see what has probably been a long-standing indolent tumour in the temporal lobe of someone with epilepsy, a ganglioglioma should come high on your list. And the words that I tend to use are, this most likely represents a glioneuronal tumour, in brackets, e.g. ganglioglioma, close brackets, or another indolent glioma, in brackets, e.g. pleomorphic xanthostrocytoma, close brackets. And I tend not to try and take a big swing hoping that I nail the diagnosis, because the similarity between these lesions is really, really high. But let's have another look at a case. 16-year-old, seizures, otherwise well. We see a lesion in the temporal lobe, located peripherally. The thing that's striking about this lesion is just how vividly it enhances. Now, we saw that gangliogliomas can do this, but they tend not to. They tend to be more intermediate in their enhancement. And here, with the eye of faith, maybe we can see a little dural tail. And if this is a real finding, then that is quite helpful. No, it's not a meningioma. We think of dural tails as being synonymous or pathognomonic of meningiomas, and it's something that we teach medical students, unfortunately. Because not only is the dural tail not pathognomonic of a meningioma, often it's not even the meningioma. The reality is that a dural tail is enhancement and thickening of normal dura adjacent to a tumour. And if you look carefully, depending on how you do your contrast, you can actually distinguish tumour versus dural tail. And if you biopsy just the dural tail, studies have shown that in some situations, particularly when it's smooth, like it is here inferiorly, you won't find any meningioma in there. And therefore, other processes that abut the dura can cause dural tail. And that ranges from cerebral metastases, not just dural metastases, but even parenchymal metastases or cortical metastases that reach the dural surface. But also pleomorphic xanthostrocytomas, solitary fibrous tumours, previously known as hemangiopericytomas, and even glioblastomas can cause a dural tail. In fact, this is a lovely example of a dural tail in what is definitely an intraaxial tumour. So I think separating the idea of dural tail from meningioma is a really worthwhile one. And when you're presented a tumour in this epilepsy setting, if you do see one, it strongly favours pleomorphic xanthostrocytoma because of these LEATs, of these group of glioneuronal tumours, it's really the only one that's recognised as having this feature, and that's what this case was. And so now that we've had a look at a couple of cases, we can start to organise them according to at least how much enhancement they have. At one end, we have DNETs, which we haven't seen yet, but are really non-enhancing. About 10% may show some enhancement. To pleomorphic xanthostrocytomas at the other end, where they typically have very vivid enhancement, and gangliogliomas and gangliocytomas in the middle, recognising that they can have very variable enhancement. Here's another case, 25-year-old male. we have a cyst with a mural nodule. And when we go to enhancement, we have fairly prominent enhancement. This is not windowed terribly well. Importantly, this lesion isn't actually in the temporal lobe. It's in the frontal lobe and insula. And this is a pilocytic astrocytoma. And I just included here really briefly because pilocytic astrocytomas are one of those tumours that we tend to think of purely in the setting of pediatrics. And we tend to think of them purely in the setting of the cerebellum. But the reality is far from that simple. Yes, the majority are like that. But in patients with NF1, pilocytic astrocytomas tend to occur throughout the optic pathway and hypothalamus and thalamus. And in adults, and I don't mean elderly patients, but between the ages of 20 and 40, pilocytic astrocytomas aren't that uncommon, but when they occur, they tend to occur supratentorially, typically around the ventricles. They don't have a particular predilection for the temporal lobe, and they don't necessarily present like this with a well-defined cyst and a mural nodule. They can look uglier and more heterogeneous. They can look very, very similar to a ganglioglioma. Let's have a look at another case, 25-year-old, first seizure. Here we have a lesion in the temporal lobe. It shows quite a lot of enhancement peripherally, but centrally quite heterogeneous. There's some surrounding edema. But note that it's not really necrotic. There is this component that's sort of fluid, but most of it is solid. And when you compare to the post-contrast, this whole solid component doesn't enhance all that vividly. And on susceptibility weighted imaging, we see that there is quite a lot of calcification. And this is a papillary glioneuronal tumour. They're rare. You'd almost never really suggest them as your first diagnosis. You'd accept the diagnosis when the pathologist told you that that's what it was. Another case, 20-year-old male, another lesion in the temporal lobe. Again, high T2. There's some areas of low signal here, which if we look at susceptibility weighted imaging, again is calcification. But when we go to post-contrast, we see very little enhancement. There is some, but it's really quite low level. And this is one of those plenty tumours. Polymorphous neuroepithelial tumour of the young. I always have to look that up. What you might have noticed is that a lot of these conditions start with the letter P, which is a little bit annoying because it makes remembering them even harder. We start with pilocytic astrocytomas that are common, probably even more common than the others, even in adults, but they tend to not be in the temporal lobes so much. Pleomorphic xanthastrocytomas are relatively common. They're usually very vividly enhancing and can have a dural tail, which if present is really helpful. And papillary glioneuronal tumours, they're rare, they have mixed enhancement, whereas plenty are also really rare in the young. But I mean, all of these are in the young, so I don't know why plenty gets to have in the young in their name and the other ones don't. They're rare and they have not much enhancement. So if we're trying to think about what features might be helpful, enhancement again can be useful in slotting these other entities in there, with plenty being not much enhancement, papillary glioneuronal tumours being of intermediate enhancement, whereas pilocytic astrocytomas tend to have more vivid enhancing mural nodules. Okay, so that now brings us to cysts and bubbles. And this is the most important part of this talk. Not because these tumours are common or entities are common, but because this is where, by not thinking of them, you can end up having unnecessary surgery and incorrect diagnoses. Let's start with this one. 55-year-old female, headache and seizure-like episode. And we see here a lesion that's in the subcortical white matter. It has lots of these small, well-circumscribed, rounded lesions. Maybe you'd be tempted to call them cysts, and I suppose they probably are, but I don't think they're fluid-filled so much. Importantly, the adjacent white matter is very, very normal. There's no edema surrounding them, and these areas do not appear to be embedded within a tumour. They are the abnormality themselves. But when you perform FLAIR, they don't fully attenuate as you would expect a perivascular space to attenuate. They don't enhance or show very minimal enhancement. And they don't show diffusion restriction. This is the classic appearance of a multinodular and vacuolating neuronal tumour, an MVNT. These are recently described, and they're super indolent. So indolent that they don't grow, they don't invade, they don't get bigger, they don't metastasize. And unless you need to operate because of uncontrolled epilepsy, these don't need resection. And this is one of those conditions where you as a radiologist are probably the person most familiar with this entity, and it's your responsibility to really advocate for the patient to not have a resection unless they need it for epilepsy management, and to just follow this up. And you might need to follow it up at very short interval such that the patient and the treating team are happy that they're not missing the chance to treat. And that's sometimes, if the patient or the surgeon are very, very anxious, it might mean repeating the first study within weeks of the first one. And that's okay. Your aim here is to prove that this can be watched. Have a look at a bunch of examples. They all look just like this. There's not actually any point showing multiple examples because they all look very, very, very similar. Small clusters of subcortical areas of high T2 signal that doesn't suppress on flare with surrounding normal appearing white matter. We should contrast that with this patient who's 40 years old, who has a very high T2 signal lesion, so much so that it's even difficult to hear under this windowing separated out from adjacent CSF. And when you do flare, the center of it attenuates, whereas the margin has this peripheral high T2 rim. It doesn't enhance. Where is it? There it is. And it shows facilitated diffusion restriction, which really doesn't surprise you because you know this is going to have a lot of extra fluid in there. And there's no abnormal signal on SWI to suggest blood product or calcium, and nor does it have any elevated CBV. And this is a very typical appearance for a DNET. And the thing with the DNETs is that they are a tumour embedded within which may be bubbles or areas of fluid-like signal, and that those central areas within the tumour are those that suppress. Compare that to the MVNT, where really the whole lesion are the little areas of roundness, and that they don't suppress on flare. The other big difference is that DNETs almost always involve primarily cortex. Now, if they're larger, they'll extend into the adjacent white matter, but they are centered on the cortex as much as possible, whereas MVNTs are subcortical. But one thing that you might have noticed is that this T2 bright rim, which is described in DNETs, looks almost identical to the T2 flare mismatch that we talked about in astrocytomas. And that's because they are. There's no monopoly on this appearance from astrocytomas or DNETs. All we're seeing here are two different terms being applied to the same process, a relatively well circumscribed lesion that has pushed and compressed adjacent brain, but the center of which is very fluid rich, so much so that when you perform flare, there's enough attenuation to significantly drop T2 signal. And there are other tumors that can do this as well, which we won't go into them because all of them are also rare. But this same appearance is not just of these lesions. So you need to think about context, age of demographic, and where the tumor has arisen before you start using this to define a diagnosis. Arguably the most important case for today, and it's not even a tumor. Here we have another very, very bright T2 signal abnormality in the temporal lobe in someone who may or may not have had some seizures. When we perform flare, it completely attenuates. Here we've got the spectrum from MVNTs where there's no attenuation to DNET that has incomplete flare suppression with that flare bright rim around the margin to this lesion where it completely attenuates, just like ventricles do. And that's because this is filled with CSF or essentially CSF. There's no enhancement. And if you had DWI, it would show very facilitated, the same as CSF, because this is a perivascular space. But I hear you ask, what about all this edema? We're taught that perivascular spaces, like the ones that we typically find around the anterior commissure, the way to distinguish them from a lacoon is that they don't have surrounding gliosis and shouldn't have surrounding edema. So surely this is a tumor. Well, this is not the same kind of perivascular space as you see elsewhere. This is what's known as an anterior temporal pole perivascular space or perivascular cyst. It's unfortunate that that's the term that's been used because they're not always in the anterior temporal pole, but they are always related to a branch of the MCA that indents the cortex. Right there. And you can see that in multiple planes, like here. And the cyst is always abutting that knuckle of the vessel. And it's thought to be that that vessel with pulsation up against the brain, just where a perivascular space or a penetrating artery passes, impairs the normal perivascular flow of fluid and results in this cyst. And the result is that you also get gliosis or transependymal edema, or not ependymal, translesional, transcystic edema in the adjacent brain. These cysts can change in size. The amount of edema and gliosis can change over time. But these are not tumours. But if you were to biopsy this or resect this and send this part of the brain to a pathologist, they are likely to find some reactive astrocytes. And when they run their IDH, they will find that there's no mutation. And it's possible, and it has happened, that patients will undergo unnecessary surgery and then be told that they have a glioblastoma and then undergo radiotherapy and chemotherapy and be told that they'll be dead nonetheless within a year because of a perivascular cyst. And again, you are likely to be the person in the room that knows the most about this lesion. And it's your responsibility to advocate for this diagnosis and to push back against people wanting to chop it out immediately. So where does that lead us? Well, a few final thoughts. Firstly, how tumours cause epilepsy. They do so via a number of different mechanisms, and some of those mechanisms are tumour-related, and some of those are location-related. And that your interpretation of these tumours should really be shaped not just by what they look like and where they are, but also, very importantly, upon who they're in. How long have they had epilepsy for? How old are they? Is there anything else that we know about them? We've seen that a surprising number of these lesions start with the letter P, but that in most instances, it doesn't really matter which of these it is because their imaging features overlap greatly. Their therapy is very similar, resection for management of medically refractory epilepsy, and that even though they have typical appearances, each of the lesions has a wide variety of appearances. But most importantly, we have a couple of do not touch lesions. MVNTs, which are very indolent and can be safely observed, as well as anterior temporal pole perivascular spaces that aren't even tumours. Thank you, and see you next time.
Wow. Well, we don't expect anything less than awesome, and that is exactly what Frank delivered. Thank you very much, Frank. And for all you neuro and head and neck fans out there, check out what we have lined up in Radiopedia 2025. We've got imaging and anatomy lectures, interactive cases, workshops, all produced and delivered by a world-class lineup. Well, that is it for now. We will be back in a few weeks for the next live stream. So thank you for your company, and please do check out that registration page. See you later.